Good morning, everybody. You ready for round two? For those of you who are only attending one block, we're doing 3 blocks today. So you're going to hear our opening spiel and our closing spiel multiple times. So we hope to improve over the course of the day. I know I get funnier as the day goes on, so you're in for a treat. So my name is Kaylee Berger. I'm the Assistant Commissioner for Community-Based Strategies and Prevention at ACS. I've been responsible for leading the RFP planning for the Prevention 2020 RFP, which came out about 10 days ago. So I hope you've all reviewed that online. You are here today to learn about some of the evidence-based and evidence-informed models in the therapeutic and treatment category that are being offered in the RFP for solicitation. Today, during this session, we'll be hearing about functional family therapy and trauma systems therapy. And I want to, before we get into some details and logistics, I want to introduce our Deputy Commissioner, Dr. Jacqueline Martin. She oversees the entire prevention portfolio and has been a tremendous champion for the work and in the planning for this RFP, and many of you know her, and if you don't know her, you'll get to know her. So I'll introduce her to welcome you all here today.
Thank you, Kaylee. So hello and welcome again.
There we go.
Oh, sorry about that. So this is an exciting time in prevention services. As you may know, we've been working for the past year on developing the new RFP for prevention services. With this RFP, we are seeking to build on our success in prevention services while modernizing the way in which we meet the changing needs of families across the city. ACS is committed to delivering child welfare services in a socially just and culturally competent manner. And our experience indicates that a community-based approach to servicing families further meets these goals. The RFP is informed by over a year of research, which included extensive input from more than 300 stakeholders, including families, parent councils, all levels of prevention provider staff, subject matter experts, legal advocates, and clinicians. It also included, over the past year, over 50 or more than 50 focus groups, and listening sessions, and more than 100 expert interviews, in addition to literature reviews, jurisdictional scans, and a comprehensive data analysis. ACS also received robust feedback on the prevention concept paper, which has been incorporated into the RFP. As many of you in this room know, ACS leads the country in the implementation of evidence-based, evidence-informed, and promising practice models here in New York City. Over the past 6 years, these research-based programs have demonstrated success in meeting ACS goals of reducing the likelihood of a child entering foster care or experiencing abuse or neglect, often in a shorter time frame than traditional case management services. Through this procurement, ACS intends to expand the use of evidence-based and evidence-informed practice citywide. ACS is also planning for compliance with the Federal Family First Prevention Services Act, federal legislation that was passed in 2018 that contains new requirements for evidence-based and evidence-informed services. We are building on the lessons learned from implementing evidence-based and promising practices, and are encouraging agencies interested in proposing to think strategically about implementation, which should include readiness activities, fit between model and program, resources to sustain practice change. And to support this work, ACS seeks to invest in programmatic supports necessary to sustain high-quality implementation on a city-wide scale. Presenters will be sharing with you during this time the implementation support that is available for each model, And we look forward to ongoing collaboration with providers as we negotiate the contracts. I'll turn it over to Kaylee now, who will give you more details. Thank you.
All right, details and logistics, my specialty. I'm going to ad-lib a joke about that every time. So how was that one? As funny? No? All right. I'll get on it. All right. Thank you for the feedback. Feedback is a gift. Okay. We are very pleased to welcome you today. We already had Block A this morning. This is Block B, which will cover functional family therapy and trauma systems therapy. Following this, we'll ask everybody to leave for lunch, and then folks can come back if you're registered for Block C, which will cover multisystemic therapy, family treatment rehabilitation, and special medical. That'll be this afternoon. Just some details here. Each presenter will have 25 minutes to talk about their model. And we've given significant guidance to each presenter on what they should include in their presentation. So we received over 400 comments and questions to the concept paper. We distilled all those down, we put them in a tracker, we identified the key themes, and we provided those to the presenters to make sure that they address all the questions that you surface. So we're trying to get out ahead of some of the things that you're curious about regarding these different models. This is a procurement-related event, so we have a lot of rules that govern what we can do here today. One important rule to note is that there can be no questions asked at this event. Any questions that you have can be emailed to the RFP email box, which we'll share with you at the end of this event. The other thing to note is that we have pre-proposal conferences, which are separate events, coming up in July, on July 8th and 17th, and that's a forum for you to ask the questions live here at the Children's Center. So we'll give you more details on those at the end as well. A couple other notes. All the conversations, if you want to follow up with the model developers or model representatives and have conversations with them about the model, that all needs to take place outside this room and outside this space. That's for you to do on your own to follow up. And also, all the materials that are going to be covered today, the presentations or handouts that are presented by the presenters here are all available online. That link is part of the Eventbrite. We'll share the link with you again at the end, but don't worry about taking too many notes. All that will be available to you at the end of the session. It's already posted online. And the video of these sessions will also be posted online. So if you have colleagues who weren't able to attend, that's a publicly available link on the ACS website. Anybody can go to it. You can share that with them so that they can get the same information you received today. And just another note about the procurement, you'll notice there's different catchments in this procurement than we've previously used. So the therapeutic and treatment models talked about here today are being offered either borough-wide or city-wide. Most of them are borough-wide catchment and competitions. MST CAN and special medical are offered on a city-wide scale. So just to note, if you're applying for any of these models that are borough-wide, you're expected to serve the entire borough, and for the city-wide competitions, you'll be expected to serve the entire city on those contracts. We are trying to get these models to be expanded so that all families have access to them citywide, and that's the approach we're taking, and you'll notice that if you look into the RFP. So that is, I think, the gist of what I wanted to cover in terms of details and logistics, and so I think we'll be able to get right on with the presentations here. Just to note, we have two functional family therapy presentations. There are two organizations who offer model developer support, and so you'll be hearing from both of them today. So the first organization is Functional Family Therapy, LLC. So I'll invite up Dr. Michael Robbins and Annie Neerman, who will be presenting on functional family therapy. Thank you.
We don't have time to be able to be funny, so and trust me though, by 4 o'clock I'd be hysterical. So Kaylee, I hope it goes really well for you the rest of the day. I'm Mike Robbins from Functional Family Therapy, LLC. I am the Clinical and Research Director for the LLC. I've been working with FFT for more than 3 decades now. Started my work in 1988. And continuing to do work on the model, implementing it worldwide. We also have
Hi, everybody. Good morning. My name is Annie Neerman. I'm a consultant and trainer with FFT, and it's great to see a lot of friendly faces here and look forward to meeting more of you. I was racking my brain for a funny joke. My 11-year-old loves telling funny jokes, which maybe they're not so funny, but of course I couldn't come up with anything last minute, so maybe a little bit later. But I'm here, I'm from New York City, actually, and I started working as an FFT therapist. I like to pretend that it was 3 years ago, but really it was about 17 years ago. I was working as a therapist in a community-based mental health clinic in Bushwick, and then moved to be the supervisor of a reentry program in the South Bronx that actually worked with families throughout the city. And for about the last 12 years or so, have been working as a consultant and trainer, and have had the pleasure to work with most, if not all, of the organizations and agencies here in New York City that are implementing FFT. So it's great to be here with you all.
So we'll be going back and forth over the course of the presentation, just presenting different pieces of it. And you're going to hear a lot from different developers through the day about the different evidence-based programs that might be available. So rather than just kind of get up here and just kind of talk about nuts and bolts and the procedures of FFT, we have provided everything, as Kaylee was saying, on an online link that gives you a lot of the details about exactly what it is we do, how we do it, the types of families we serve, other parameters that are there. We'll cover some of that in the presentation, but we thought it'd be better to talk some about principles and what to look for as providers when you're making a decision about what kind of evidence-based program to select. And we have a lot of experience working around the world and developing relationships with systems and with providers to try to identify what actually makes sense for a community. And so we've tried to distill some of that down into a few principles that we'll follow through here with over the course of the next 25 minutes. A lot of it has to do really with just what we value. Ultimately, when we're talking about change for families and for kids, that change doesn't occur in a room like this. That change occurs when you have a provider sitting in the room with a family. And it's making sure that when they're there doing their work, that they have all the support necessary, all the training necessary to be able to deliver a model with fidelity. I remember Allison Metz, when she was presenting at one of these forums, she was talking about families not benefiting from services they don't receive. So everything comes down to making sure that families get high quality care. And so this begins that process. So as you're thinking about what to do and what programs to select, the types of questions we would recommend asking have to do with fit. The first is, does the program fit with your agency, your staff, and their values? So what is it that's important to you? What are the things you want to see done? Does it fit with your families in the community? Does it work? Does it change lives? Is it effective? And if so, is it something that you guys can do well? And can it be sustained? You don't want to be a flavor of the month. We don't want to have this be, we come in, we do a training, and we walk away. We want to make sure that a decade, 2 decades later, the programs continue to grow and there's local expertise. So for us, these are the core values that we'll talk about as we move forward. For FFT, any training we do, if I walk out to train a team anywhere in the world, the first things that I'll talk to folks about are respect and strength. This isn't lip service. It's actually walking into the room and finding out what is important to the values of an agency, what's important to the values of the therapists that are right in the room with you. FFT is ultimately a respect-based model. We don't come in with a preconceived notion about how a family should behave. We don't have some value on that. We match everything in a way that's respectful and find strength in what people bring to the table. It's also a family-based model. Everything we do is relational. And ultimately, it's about building partnerships with the communities, building partners with the agencies. In order for us to be effective, it's not us coming in as experts telling you what to do. It's us coming in and developing a relationship to work effectively together, because we are not experts in your community. You are the experts in your community. We have to listen, and we have to build a relationship where we work effectively together. There's a lot of familiar faces that I see in here, but there's also a lot of new people. that we're just starting that process, and I hope this, engenders some interest in you as you move forward in that process, because this is relationship building. In order for it to sustain, that relationship has to be carried forward on the ground. In FFT, when we talk about that fit with family and community, the goal in FFT is not to create some healthy or normal family according to our ideals or some mental health ideal. It's to help families achieve changes that are meaningful to them, that match to them, to their values, their resources, and their context. The term function in functional family therapy does not refer to making dysfunctional people functional. It's kind of an odd name. It was, when it was originally developed in 1971, there wasn't a lot of thought going into, oh my God, how are we going to sell this? How are we going to package it? It was really just described as functional family therapy in early 1980s. The idea around function is not to make dysfunctional functional. The idea is that everybody's behavior is motivated to achieve an outcome in the most important relationship in their life, their families. Those relational payoffs are functions. So what is the function of a behavior? What does it serve in that dyad? What does it serve in that family? So functional doesn't refer to dysfunction. It actually refers to a concept of matching. We're going to work hard to identify what those relational payoffs are, and we're going to organize everything we do to match to those relational functions rather than change them. Our intent is not to have everybody look the same when they leave. The idea is for this family, with their values, their resources, and the functions in that system, we will match to them to give them healthier and adaptive ways for them to negotiate their lives.
Great. FFT enters into the work with families, understanding that many families, both understanding and respecting that many families don't necessarily want to engage in the work with us. And we really believe and understand that families have a lot of very good reasons to start from a place of anti-motivation or resistance or hopelessness. Many of the families that we've worked with have been through many other services, worked with many other service providers in the past without having had much success or the changes that they were hoping for, or even in some cases, having engaged in services that ended up making things worse for them. So this is a model that really specializes in being able to engage families who otherwise don't want to be working with us and bring them to a place of openness and willingness and receptivity to this change process. One of the families that we're currently working with that has sort of found a way into my heart these days is a family that includes a mom, her 17-year-old son, and 13-year-old daughter. And this is a mom who, after 10 years in a very highly abusive relationship, after leaving that relationship, has been in bed essentially for the last 7 or 8 years. Her 17-year-old is on probation for assault charges in the community. And there's also patterns of assault and physical aggression of this 17-year-old towards his mom and towards his younger sister. It's a 17-year-old full of tremendous rage and tremendous disappointment and tremendous hurt. It's a family full of tremendous hurt, tremendous pain, tremendous disappointment, without much hope. They had been involved in many other programs prior to finding their way to an FFT therapist. So this is just sort of one mini example or mini profile of a family that we work with in FFT. And the therapist does everything under the sun to be able to make a connection with that family, to build trust, to build hope, to build credibility, so that family is willing to give us a go, to give us a try. We come at this work knowing that more isn't the way to go, that less is often more. And we're able to engage in some really effective change processes with the families over the course of a few months, 3 to 5 months or so, 12 to 14 sessions. We really believe in the inherent strength and dignity of families, and that they're able to really pull on tremendous capabilities, intelligence, skills that they already have in their, as they come into the work with us.
So FFT works with complex families, as Annie's saying. We don't work with a behavior problem. We actually work with families and individuals and families, which means you have to have a real comprehensive focus on what are the risk factors and protective factors in a system. You have to pay attention, as Annie's saying, to both the strengths as well as the risks. To do this, it's a complex psychotherapy. A lot of people think of manualized approaches as being very rigid. You just kind of walk through a list and check things off as you move forward. That's not the case in the therapies you're learning about this morning and this afternoon. They're complex psychotherapies. Therapists need to learn how to think. They need to learn how to react and do so in ways that make sense. It can be overwhelming. It's a tremendously challenging job. It requires a lot of support to get it right. In FFT, we have extensive research and really clear clinical descriptions about how to manage that process in a way that's stepwise or phase-based. So therapists have a nice sense of what they're doing at any point in the process. Each phase has its own unique goals, has its tasks, has an assessment focus, and also has interventions that are linked to it. So at any point in time, a therapist has recommendations and ideas about what it is they're trying to accomplish and strategies for getting there. Early in this process, for families that are very difficult to reach, that are often recalcitrant, as Annie said, they're not just unmotivated, they're actually anti-motivated to change. You need to be really focused on engagement. And all of the programs you're hearing about today, and I'm sure I missed Joan's presentation earlier, but I'm sure they talked a lot about what it takes to engage really difficult to reach families. FFT, MST, any of the programs are going to talk about those heavy front-loaded work you have to engage in order to get people to come to you. The burden of responsibility for bringing people to the room is on the therapist. It's a tremendously difficult task. But we have real clear ideas about how you negotiate those early contacts to effectively engage people into a treatment process. What is it they have to gain by participating? How you get that hook to bring them into treatment is critical. Once you get them there, the shift really occurs to move more about what that person needs to hear to what that family needs to experience and understand with respect to one another in terms of motivation for change. FFT works very hard and very fast on initially engaging people into treatment and then motivating them into a change process. This doesn't occur over a long period of time. We have to get in fast and get families out of harm's way as quick as we can. The next part of the process is making sure we understand the relational functions and payoffs, and then everything we do after that is matched to those relational payoffs. And in FFT, the behavior change phase is the longest phase of the treatment process, and it's where we're teaching skills, where we're talking about improving family functioning. We're talking about developing more effective conflict resolution strategies, problem solving, negotiation, communication. But those pieces, thank you, those pieces are only set the stage for also developing other complex skills. It's unrealistic to expect that if you improve family functioning, other critical risk factors like substance use are just magically going to get better. There may be some improvement, but if you want to see something change, it better be on the table in treatment. So if trauma is a part of the referral, you better be addressing trauma. If substance use is part of the referral, you better have substance use on the table. So it's not uncommon for therapy to include things like communication training, as well as complex tasks like coping with urges and cravings. In the generalization phase of FFT, it's where you lock in the changes you've made inside of the family and individual family members, and you're extending those into multiple systems, and you're also planning for what might come next. So here you will be folding in other treatment services if you're looking for formal pieces, as well as informal pieces like connection to pro-social networks that are relevant to the family. if you don't plan for relapse or you don't plan for future challenges, change can be really short-lived for a family. You can't short sell them by rushing to finish treatment without giving them ideas about what's going to come next. So that's in a really quick nutshell what the FFT model looks like. Ultimately, your therapists have this kind of tattooed on their brain somewhere, and at any point they're using this as their guide for what you do every single moment with your family.
We work with over 350 sites, not just here in New York City, but throughout the world. If you actually go on our website, you'll be able to find this and click on any site anywhere that's listed on here and get a sense of who the provider agencies are that are working with us. Here in New York City, we really here have been a template for the work that's being done throughout the rest of the country and throughout the rest of the world. Many of your organizations have probably hosted visitors from the Netherlands, Denmark, Australia, Singapore, other places throughout the US. Folks who have come here to see what good quality FFT looks like. We've been doing work here for, nearly 20 years. We're working in all of the 5 boroughs throughout New York City. And with that, we know that we're really working with people from all around the world, right? In this amazing kind of mix of people from every country there is. Nationally and internationally, we complete treatment with close to 80% of families. And you'll see that here in New York City, we even exceed that national and international standard. We have some of the best, hardest working, committed, dedicated, relentless therapists there are. So special shout out to all the therapists who are in the room here. You've seen that we've worked with over 14,000 families, with an average length of service of 186 days. It doesn't take a long time. Doesn't take a long time for us to do really nice quality work with families that's really impactful to their health and their well-being.
So in terms of evidence base for FFT, there's 5 decades of research supporting the intervention. The model was initially developed by Jim Alexander at the University of Utah in the early 1970s. And a lot of the early work was done to identify how families that had an adolescent that was delinquent, how they operated, what happened with them, how they interacted with one another, and how that was different from families that did not have a delinquent adolescent. So there was extensive research to kind of understand kind of basic processes that informed the evolution of an approach. The early studies demonstrated the impact of the intervention compared to alternative treatments. And by the early 1980s, the model was really fully formed and identified as functional family therapy. That early 1980s, the model was also described in the Anatomy of Intervention model, which described the 5-phase approach to doing the work. Throughout the 80s, there was a lot of research looking at how the model worked in child welfare, other social services contexts. And they began to get replicated in others by a variety of people, including folks doing work in substance use, ADHD, and with rural families in southeastern Ohio. In the 90s, the research continued to evolve, and there was more dissemination. At that point, work was going on in Sweden, and the beginning of work with substance users in New Mexico. Became a real prominent research program on FFT. The important part here is that FFT has been shown to work in dozens of studies for behavior problem kids. But the results don't just stop there. FFT is successful in actually improving the lives of younger siblings, and parents that are involved in the treatment also experience significantly less distress, less depression, less anxiety. So it's an intervention that ultimately keeps families together, keeps them safe in their community, and has a broad impact across all family members. We do a lot of work trying to make sure that what we do, we're able to do well. And so the same level of attention that went into developing the intervention and the research to really understand how things operate in the room, we've applied that same idea around work we're doing in the implementation of FFT. In the early work, when the intervention was initially identified by the Blueprints for Violence Prevention as a model program, there was a lot of push to move this into the community. There were some hiccups. It took some time to actually get it right. Since 2007, there have been 20 studies of sites that are implementing FFT, supported by FFT LLC, 20 peer-reviewed published studies demonstrating the impact for kids and families. These studies cut across 7 states and 6 countries, real diverse communities. So we know we can get it right. We know what it takes to get it right, and we can actually demonstrate outcomes in your communities. So it can be done well, but it requires a lot of careful attention to details to get it right.
And that getting it right is really important. It's one thing to have an evidence-based model, but if it's not implemented and supported in the right way, you won't have the outcomes that you were hoping for. So we've worked really hard over the years. We know what works in terms of training and implementation and support that sites need in order to have really well-running programs that make significant changes in the lives of families. When we train teams between 3 and 8 therapists. We have different levels of training based on how new a team is to learning the model. Our first year of training is the most intensive. It's geared toward training a team of clinicians in the clinical model. And over this first year of training, we have 5 on-site interactive trainings with the therapist team. The trainings include an array of live supervision, video, role play, case example, theory. The goals of the trainings are really to help therapists take the model and be able to put it in action with the families they're working with, and to feel confident and believe that they're able to kind of effectively use the model as designed. I think that, one thing we find is that therapists generally leave the training pretty excited and pretty motivated about the work that they're doing. Yeah. Great. Okay, yeah.
So in terms of what makes FFT successful, this idea around localizing experience and that training model that Annie just quickly went through, the idea is we're going to localize the skill, localize the knowledge in the same way we're developing skills and addressing problems with the family. Our idea is developing a partnership with community agencies where we localize our knowledge and our expertise there, and so that ultimately the agencies are able to be successful in implementing FFT. And actually take the leadership in implementing FFT. When we look at agencies that are 10, 15 years out, we ask them what were the key pieces about success. And it didn't come down to us and our knowledge. It actually came down to their level of support and belief in the work, and also the relationship that the referrals and the stakeholders had in the program. 45% of what they said accounted for outcomes were about those relationships. Yeah, the team matters, having a high quality lead, all that matters, but ultimately it is about those relationships and building those partnerships. And so we appreciate the opportunity to be here today to at least start that process and have a conversation. And we look forward to you guys reaching out to us outside of this room, of course, and outside of this building. But in the near future, we hope to hear from many of you. Thanks so much for your time. Got it?
All right. Got it. Mm-hmm. I'm a jack of all trades. Okay, our next presentation is also on functional family therapy, so we'd like to welcome Dr. Tom Sexton of Functional Family Therapy Associates. Welcome.
Hey everybody, nice to be here. Thanks for the invitation from ACS, I really appreciate it. I'm going to talk and then orient myself to this IBM PC computer here, which makes no sense to me, so I'm going to hope I push the right buttons. That's the best I can do for an early joke, by the way. So it's not a very good one, but we're moving on in the day. It's, like I said, it's wonderful to be here. It was 20 years ago, I think, when I was first at an ACS conference and we were doing this. And in 1999, when we were beginning to roll FFT out in New York City, it was an experiment, as Joan said earlier this morning, a real experiment. Look where it's come 20 years later. The RFP is incredible. The work that's being done in New York City is marvelous. This experiment has really changed the world in many ways, and it's really brought evidence-based practices to a place where they're institutionalized and they really can make a difference in the world as we move forward. My name's Tom Sexton. I'm president of Functional Family Therapy Associates. I'm a retired university professor. That's why they call it emeritus. I think that means wise, not old, but I'm not totally convinced of that. So that was supposed to be the other joke, which is why I didn't lead with it, because clearly it wasn't very good. I've been doing functional family therapy for a very long time, co-authored many of the articles with Jim Alexander and other colleagues in the room, and I want to thank Mike and Annie for their work this morning. So as you know, FFT is an evidence-based treatment model for families involved in all sorts of different systems. We also work around the world in many, many ways. Family-focused. It can be office-based. It can be home-based. The notion here is that from an FFT perspective, we support the family in many, many ways. We don't just support them in the treatment room. We support them in their life. We support them in the important things that they have to accomplish. We support them in their daily practical needs and activities that they have to get done. So what FFT does as a change model is it helps provide families with a pathway to change. We have some very scientific terms for such a scientific model, but from our perspective, families get very stuck. They get enormously stuck. They have resources, as Mike said. Families have the tools that they need. They can get stuck in corners. So what we provide, what FFT provides them from our perspective, is practical help. Ways to get what they need done so they can maneuver the system. Ways to help them engage in the treatment system. Now, as Mike said, families are reluctant, if not recalcitrant, in their desire to join in us and help with changing. And it's remarkable given all that they have to experience. So finding a way to engage and motivate them in treatment becomes an essential first step. And as Mike said, it is important from our perspective that therapists take that responsibility and don't put that on families. There's no way in which we should think that they're going to come to us engaged to do the things that we want. We also work really hard to help develop skills that will stabilize families and help prepare them to be self-sufficient as they move forward. Now, self-sufficiency is an important issue for us. We do not expect them to come back. We expect them to live on their own with their skills in the way that they live, in their values, and in their culture. And then our goal is to help before we're finished so that families can keep the changes up that we've helped them make. What that means is you can make a lot of changes, but if they don't maintain those, and maintaining changes is not so easy. I won't ask for a raise of hands, but if I were to ask how many of us in this room have started an exercise program, there would be a lot of us. If we were to ask a show of hands, how many continue to start them? That would be me. We start them over and over and over. Maintaining change becomes an essential thing. So FFT, what's remarkable about this model, and I've been involved for a very, very long time, is it is not a static model. FFT has evolved over time a little bit like people do. We were all born into the families that we're in, right? We came with an identity from that family, but we became individual people. So FFT in all of its studies has grown and developed as the world has changed, as the research has changed, as what we know about how to help families have changed, and as the complexity of families have changed. So the emerging and the changing nature of families, what's nice about FFT is that we have let the model evolve around those changes over time. Lots of publications, as Mike said, they go on and on and on. You can find them. There's a number of things that make FFT, I think, effective. First of all, it is, as Mike said, family-focused and alliance-based. That means we work together, and from our perspective, therapy happens based upon two experts. Families are an expert in their life. They know their values, they know their culture, they know how they work. But families are not experts in how to change. If they were experts in how to change, they would have. They wouldn't be in our room, they wouldn't be in our service. So the expertise of FFT is not around values or how a family works. The expertise around FFT is on helping a family through the process of changing, which begins with being engaged. It begins with becoming motivated. It begins with changing patterns of behavior in your family, and it begins with keeping those going. Evidence-based, not only in its training and its decision-making, but it's an outcome. We have a very specific training program, as I'll talk to you in a minute. Relevant help, and the important part is that we have a systematic way of including family voice in every decision we make. Now, it's not just something we say, it is something we do, and let me show you how that works as we move along. As an evolving model, FFT has a core philosophy. This core philosophy hasn't changed a lot through the years that FFT has been going. It's stayed stable. The ways in which we train, the way in which we articulate has changed because the nature of our work has changed in the last 30-some years. Family-based and relationally focused. As Mike said, collaborative and alliance-based. Family voice, not in general, but family voice session by session by session, so that they have input into each decision that we make. We want to help, as I said earlier, families be self-sufficient. And from our perspective, therapy isn't just something that happens in a therapy or a formal session. It happens in phone discussions. It happens in discussions around getting to a case management appointment. It happens in every contact with you have with the family. You've seen the MasterCard commercials. Those moments are priceless moments. They're well beyond what we would normally see as therapeutic, and they're enormously important. We have learned over the years to become trauma-focused. I mean, clearly, when we started FFT, we didn't have the notion of trauma, but we've incorporated trauma focus into almost each activity that we do, and we've become much more developmentally specific as we've developed and moved along. We realize that kids at the upper end, young adults in the spectrum, need something quite different than kids younger, than adolescents and things like that. And Mike said this extraordinarily well. Here is the key. Evidence-based practices are appropriately worrisome for many because they can seem like paint-by-the-number approaches. That is not an FFT perspective. We match the model to the family, and the notion is to wrap FFT around the family, not make the family fit into the box of the model. So what's important is that we match to the unique culture of the family, to the culture in which they exist, et cetera. Jim and I first published this in 1999. We've published it again about 8 times up until 2007. A little simpler approach. A model moves through time. What happens at the beginning? It's engaging and motivating people. Again, as I said, people don't come to therapy necessarily looking for therapy. They come frequently here because they've been told to. And what is the objective? We have a process-focused objective here, and the idea is we have to create alliance. Not just alliance with us as therapists, but alliance between family members. And out of that alliance, and particularly and specifically focusing on helping take the presenting concern, which, by the way, we ask our therapists to talk about all the time. You don't have a relevant therapy unless you talk about what goes on every day. Not just some broad general strength, but very specific things. So we ask and talk about those, and we have techniques to make those family-focused events and family-focused problems as opposed to individual ones. Again, it creates engagement, motivation. We reduce negativity and blame. That is a barrier to engagement, and it's a barrier to alliance. What happens when you create that nice foundation? You have a different culture. In our words, we have created a page in which the whole family can sit on. And again, it's a funny metaphor. We're all on the same page, but it makes really good sense, doesn't it? If the family is on the same page about what to solve, who has to do what, where the responsibility is, the likelihood of engagement, motivation, and participation in treatment goes way up. Once you have that, it's time to build skills. Now, not just skills, it's time to change family relational patterns. So there's a number of skills that we can use to help families put them into daily practice. So what we do in FFT is the sessions, whether they're at home or in the office, are about practicing skills with real life problems, not talking about general skills in an abstract way, but very specifically. As I said with my bad exercise joke, the whole point is you can start all this, you can get families way down the line of changing And if you walk away too quickly, as Mike said, that change goes away. What does it take to maintain change? First of all, support. If you do not have support in your daily life and all the things that go on around you, you cannot maintain a therapeutic change. The world has to be, you have to be able to pay your rent. You have to have electricity. You have to have needs. So first of all, we have to get support. Second, relapse prevention. Everybody falls. Everybody trips. And when you trip, it's very easy to get discouraged and give up. The notion here is keep going and learn that falling is just another step. And then lastly, there's support, there's maintaining, and there's generalizing. The notion here is in FFT, we don't work on every single problem. We work on how the family works. So the last phase is help families take what they've learned and put it to work in other problem areas. Therein comes self-sufficiency. So the circles, it's not a straight line. It's a round and around. It's discussion. It's purposeful practice by the therapist all the way along. And the long-term goal, changing youth, sibling, parent behavior, and family relationships. Important to think about the type of skill. This has been a big evolution for us in our work. First of all, the types of skills depend on where you stand in the developmental process. We know that if families are on the lower end of our range, that you have to focus on parenting. You have to focus on safety. We know that if parents and youth are more adolescent focused, that you have to change that approach, and instead of working just with parenting, you have to do an alliance-based work with kids. Adolescents are supposed to have a strong voice. They're supposed to speak out. They're supposed to argue. That's developmentally normal. The question is we have to get parents to adjust to that change in development. And as a young adult, what's important as a young adult is that you're also able to work and treat them with autonomy and self-sufficiency and be a guide, a teacher, and a support. It is also very important to navigate the system. Families that we work with in the system have to navigate that system. We focus a lot of our attention on the skills of successful navigation in regard to monitoring, requirements, safety, things like that. We see that as within the therapist's role to monitor those things and pay attention to that. The question is, what does it take to be successful at all this? So clearly it takes a model. Now, models can be complicated. We like to keep things extraordinarily simple. So from our perspective, the FFT model is this. It is a map. I came here from my hotel with Google Maps. The Google Maps told me where to turn and where to go. I got here much more efficiently following a map. FFT is, in a sense, a map. FFT is also a lens. It's a way of looking at the world through the principles that Mike talked about and that I talked about earlier. It is very much a lens. And then it is artistic. Despite its very prescribed set of phases to go through, FFT is an art. And we try to teach our clinicians that we train to be good clinical decision makers so that they can maximize the art that they're able to bring to the family. No model can tell you exactly how to do it. But it takes a little bit more. We think it also takes very specific and thoughtful training. And so we have created, and I'll show you a little bit in a minute, we've created a very evidence-based ways to do training. We have a comprehensive measurement system that we use. We think it's quite difficult for clinicians to pick up on everything that goes on in a family. So we have an extensive baseline discharge and session-by-session set of measures that we use that fit nicely into the treatment. And then, what else does it take? Clinicians work on a case. They have to be helped case by case, session by session, decision by decision, how to stay with fidelity to the model, keep doing the model in the way that works. So it takes a model, it takes measurement, it takes training, and then it takes guided systematic decision making. Lots of areas and problems, families involved in lots of different systems, the same exclusion criteria that you've heard before. The evidence, as Mike said, this is a model that has an extensive amount of evidence, so I'm not going to go through those, but I will mention to you two actually, and that leads me to the last part of what I want to say. Here's our study from Ireland. We tried to look at changes in STQ scores in this culture, and we found that FFT works really well. But here's the most important part of this, and this goes to a study that Charles Turner and I did in 2010 about FFT. The bottom blue line is FFT. The top red line is non-adherent to FFT, and the middle line is nothing. This is not specific to FFT. Every one of these interventions can have poor outcomes if they're not done correctly. So what this spurred us to do in the last decade is to spend time figuring out how to take that red line and make it the blue line. How can we train people to do it well? Because everybody doesn't. And just because you've received training doesn't mean you did it well. This study had really good outcomes. We found the same outcome in Ireland. So what have we done to try to do that? First of all, we work with clinicians. They carry 8 cases. We have site supervisors, teams, as Mike said. Everybody trains together. We do weekly consultation on video. The plan is that we try to focus on making them self-sufficient. And what I need to say is it's extraordinarily important. Every single one of our consultants uses and does FFT. I do FFT. The tapes you see are current tapes. The work you see is current work. You have to know the inside of the model in order to be able to do it. So training involves 4 things: knowledge, evidence-based treatment planning, guided practice, and certainly an ongoing QI process. So our training model is like this. We've separated the kind of domain of training into 2 areas. First, there's knowledge, and then there's translating of knowledge into practice, and they're very different processes for teaching. It's designed, our training, to be realistic, fit into the workflow. It's implemented with a comprehensive measurement system, family voice, etc. So here's how we work. We actually do much of our initial training online. Every university in this country has decided that not only for cost-effective reasons, but for efficacy, if you want to learn knowledge not in a workshop where people will forget it, but learn knowledge online where it can be tested at every step. We have traditional training where people can talk about cases. We have case consultation weekly on video. We have practice. We actually bring live family sessions to each site. There's no off-site training. There's nowhere to go. We do it on-site. Our trainings are not consultants coming and doing PowerPoints. Our training is consultants coming and seeing live families in real time so people can learn to translate into practice. We focus on clinicians, planning, quality, et cetera, all of those kinds of things. So our AdaptAware system is a unique way of getting knowledge-based training across. So what's really nice about this is it's a wonderful platform. There's about 200 pages of text. I mean, one of the things that we realized is no one ever reads the manuals you give them. So why not put it into something where we can hold them accountable for that? So knowledge is done online. We do it in small steps so that people can do it at their workflow so it doesn't disrupt work. You don't have to leave your community. You don't have to spend all day in training. And it's got a number of different things. You watch something, you read something, you answer questions, multiple learning styles across. We are able to then ask people. We are titrating. We're able to develop local benchmarks about what works best, what people know. But not only that, we are able to then go see what knowledge they consumed. What did they get? What did they understand? Where do they start? And before we start with live families, we want to make sure that they have demonstrated their ability with the knowledge. So we're able to see how each person has done. We're able to see how teams do, and it's a really nice interactive way for us to find out about this part of training. Our training roadmap looks a little like this. We start with some webinars, we do our AdaptAware, we do practice visits. So the first year, it is heavily weighted on theory into practice, learning how to actually do this. In years 2 and 3, we focus then on our site supervisor, building the site supervisor's competency. We have a site supervision training. Care for is used all the time. And then we do certification and maintenance training from there on out. One of the biggest issues with training in evidence-based models is quickness. How quickly can you train somebody? We have an adaptive training model. We can start within 1 or 2 days when someone leaves the team. You don't have to wait months for a training somewhere else. We put everything on the team in the first year on the team site. No off-site training, guided practice, replacement training in case somebody needs to start again within a few days. We actually believe that these are relatively disruptive technologies as well. It wouldn't be a surprise if some people left your team if you start one of these models. We think we should own the responsibility for that. If you have a team of 8 and somebody leaves in the first year, we'll replace them for free. We think that's a shared goal and a shared responsibility. Implementation support, as Mike said, it's a very collaborative approach. We have lots of calls. We have lots of contact with sites. We have a measurement and reporting system for evaluation. This, by the way, you'll see in a second, every session by every clinician with every case around the world goes into our Care4 system. It is your data. You get it immediately whenever you'd like. There's no restrictions to that. We do a lot of training and adherence summaries. Here's the thing if you're going to match. It's about matching. We think it is a precision approach, and this is the work we've been doing, a precision behavioral health approach. What it takes if you're going to hit a target is you have to miss, but you need feedback. Feedback is essential. That was a joke earlier. And the essential feedback here is if you miss too far to the left, you need help moving back. If you're too high, if you're too low, you need feedback to help you hit the target. In this case, the feedback comes from the family. Session by session, we ask them how it's going, what progress they feel, and what impact they're experiencing. And as a result, we're able to titrate the model and fit it much better. We take client measurement. We ask our clinicians to look into that in each decision they make. And so here is what we think the current kind of, again, this is not for today, but let me say this really quickly. If we were to redefine evidence-based treatment, we would say that it is a model that has good foundational evidence, but that's not enough anymore. In this world, evidence-based treatments are better. We think you have to gather evidence with every contact with a client. Clients should have a voice in every sort of way. So what we ask is there's a purposeful session driven by the model, a note, a progress note that is an implementation and fidelity tool that the clinician does, look at what the family says, and then make a next plan. Evidence-based in each decision. Care4 is the tool we use to put everything in. Care4 is a sophisticated web-based tool that every case and every session goes in. It can be done on your phone. It can be done on your laptop. It can be done in homes. We're now in New York City. Our teams here are using FFT in the homes on their telephones and their laptops. They're doing everything on the laptop. And so as you can see, you don't even need to know what the screen says, but you know that my second client there, who that's an unfamiliar name, things are not going particularly well for him, and you can see the feedback comes in colors, easily consumable, and easily incorporated into progress notes for clinicians. We don't have time to read. There should be no extensive notes, and it should happen. You should be able to get it immediately, not months later. So from our perspective, the Care4 system allows us to look at all sorts of different things along the way. We've also put lots of training activities on the Care4 platform. You can actually go there and get manuals, you can get tutorials, and if you happen to need help, you can get within system videos about what to do around particular issues, and it provides you with insights about how to improve your care. As a supervisor, I can look at any FFT site and any session around the world on my computer. Now what that means is as a supervisor, I don't ask someone how it went, I look and see how it went. So I look at the exact evidence from the client, not the report from the therapist, because the correlation between what therapists report and what happens hovers around zero, not because of inaccuracy, but because you're too close. You're in it. You can't see it. So this provides a way for supervisors to have a look. We have an extensive series of measurements, as I said. We do a baseline and a discharge measurement. We measure trauma, family functioning, stability, all sorts of different things. And most importantly, session by session, and it takes 3 to 4 minutes for the family to do this. They do it on a phone or an iPad, and we get the family's voice, we get the therapist's voice on impact and progress and alliance, and it comes out of the system available for the family, available for the clinician in colorful, useful, easy ways to manage. And then, of course, as an agency, you need to know how your clinicians are doing. You should not wait on us to find that out. This system is open to the administration, to everyone within the agency, so you keep track of your data. You keep track of how things are going, not just us. Because we keep track of every session, because we keep track of every case, we can have a fidelity and a quality improvement process that's very accurate. So we measure treatment fidelity. We measure it with our therapist adherence measure. That happens session by session. We aggregate those so we can tell you clinicians by family types, by teams, aggregate that all the way up. We actually have clinicians help rate us with a SAM score. We have site fidelity, adherence summaries, and if necessary, we do improvement plans. All of this stuff is also part of the Care4 system. Thank you very much. I appreciate it.
Okay, for our third presentation, we have trauma systems therapy. So I'd like to welcome Dr. Adam Brown and Dr. Glenn Sachs. Thank you for joining us.
Thank you. Well, thank you. I'm Glenn Sachs. I'm the director of the TST Training Institute here in New York at NYU. And I'm the chief developer of trauma systems therapy starting way back in around 1999 and 2000. And this is Adam Brown, who's the chief trainer in TST, and we'll be walking you through that right now. So here is what we're going to cover. There's an awful lot to cover in 25 minutes, but we're going to get you through it. And that's our book that describes the model. It's great beach time reading, so pick it up, and it's quite a page turner. But it really describes everything, and we train from this, and our model fits for that. So why was TST developed? What is its underlying philosophy? What's the point? What's different about it? So the first thing to know is that we developed TST to give you a specific enough understanding of a child and their family in order to know what to do. And when we thought about it, it was for the families that people are most worried about, kids with lots of risk, where there's bad things that can happen. TST is developed as a trauma-informed model for sure. Trauma is very important with it, and the whole range of problems and difficulties that develop as a function of trauma. But we really, people derive, I think, the most value with the kids you're most worried about, and I'll describe how that works. So our true north, of course, is kids. And I'm going to talk to you about a kid called Shane. And think about this kid, and I'm sure the story is familiar to you in some ways. You're asked to help prevent an out-of-home placement for a 12-year-old boy, Shane, who lives with his mother and his 5-year-old sister. His father is in prison for severely assaulting his mother on numerous occasions and occasionally assaulting Shane. The assaults on Shane frequently followed his father calling him weak and not manly. Child Welfare Prevention Services was initiated shortly after his father was in prison 4 months ago. There is significant concern about Shane's aggression. He assaulted his mother on 2 occasions. He has assaulted classmates and the school physical education teacher. His mother is worried about the safety of Shane's sister. We're all worried about Shane. So what do you do? How do you help? Where do you start? And what we're about within TST is to help you with kids and families like Shane and Shane's family to really focus on what are the most important things to know what to do, because everything must be actionable. You need the knowledge that will focus you on how to help for specific things. So within that, what's the underlying philosophy of TST? You can't know what to do until you know what's going on, and that means what drives the problems. Think about Shane. He gets very aggressive. His sister might be hurt. Other people might be hurt in home, school. You have to know how to help. How are you going to direct the school? How are you going to direct the mother? How will you inform what's going on? What kind of knowledge do you need to know what to do? So here's one idea that helps. What's going on almost always relates to what we call a trauma system. And we define the trauma system in a very specific way. A traumatized child's transition to dysregulated states related to survival, what we call survival states. And it's called trauma systems therapy because of the trauma system. But the other part of the trauma system is that for lots of reasons, the people around the child are not sufficiently able to help the child regulate those survival states. So kids may be doing fine most of the time, but when we're called to help, like in Shane, it was in the moments when they're not doing fine. And we must understand those moments wherever they are. This is not office-based treatment only, although some of it is. It's strategic wherever the problem is. Once we understand, we have to intervene effectively. And it's about the service system. Kids are seen across the service system with knowledge of what drives the problem. We could begin to see within the school, within the home, wherever, how you might help. The other idea here is that although the dysregulation may seem random, it may seem to be out of the blue, often it isn't. Often what's going on is there's specific things in the environment that no one notices. Why don't we notice it? Because we did not have the child's trauma history. We can't make assumptions about it. We need to gather information to know about what leads to the dysregulation. Could be a tone of voice, a glance, whatever. We need to find it. And that provokes the survival state. And what we want to do, because if you think of Shane and many of the kids you work with, you might have a problem list that's 10 or 20 or whatever. We want to get it to a very small number that are the most important things based on the drivers of the problem, which we call the TST priority problem, always defined in one way: patterns of links between provocative stimuli and dysregulated emotional and behavioral responses. And we help people get to that, and then everything goes there. And the patterns that you discover between dysregulated episodes provides you the specific enough and actionable enough knowledge to be effective. If you think about it, what would you do to help Shane and his family? They're in desperate need of help. You know what's going to happen with Shane if he doesn't get the help he needs and the family doesn't. We all know. We know, so we have to be effective. And by focusing on the most important things, we could fulfill a principle of TST called put scarce resources where they'll work. Because we can't be spinning our wheels. We need to be dedicating our interventions to the most important things. So, with that, and Adam will talk more about the training, we provide training to give you the knowledge and tools in order to be detectives. We call people who are trained TST detectives to find the patterns and effectively address them through intervention with the child and with relevant people in the child's environment. But in order to do this, TST first has to understand organizational needs, understand how you're equipped to help. We can't come in, and I agree absolutely with everything FFT people were saying. We're not an expert in your place. We're an expert in specific things. So we need to understand, and it needs to fit, and we spend a lot of time doing that. And we build a very specific organizational plan over a couple of months with you about the allocation of resources and the partnerships you might need to make, et cetera. And we have a lot of experience with that. So what's going on with Shane? How can we help Shane and his family? Let's think about some episodes that define what we need to help. Episode 1, after school basketball, Shane heard his physical education teacher laugh, and after he was called out on strikes. If for people who don't know baseball, that means not swinging at the third strike. Shane ran at the teacher trying to hit him with the baseball bat. Episode 2, after Shane was suspended from school, his mother used an angry and demeaning tone of voice to say, "You'll never grow up to be a man I respect if you can't control your body." Shane lunged at her, pushing her to the ground. Episode 3, when Shane missed a basketball free throw, another boy said, Shane choked under pressure. Shane punched the boy in the face as hard as he could. Do you notice a pattern? Part of it is noticing patterns, and there's a way of looking for patterns, which we really, really prioritize. We got to get the facts, and it's the patterns that show us what to do. I'm going to give you an example of a tool within TST that helps you define how treatment ends up being directed. This little script, which is, we universally use it to fill in the blanks here. When Shane is exposed to demeaning comments suggesting he is weak, he responds by feeling panicked and then enraged, and then he assaults others. This pattern can be understood from physical abuse from his father following demeaning comments indicating he was weak, and feeling weak for not protecting his mother. If I told you that 80% of the aggressive episodes, even though they look different in different contexts, this was the underlying factor, that's true. So if we want to impact, we got to get at that. And this tells us, for interventions, what we need to do. So let's think about, if 80% of the episodes involve this, let's think about helping mother understand that even though her comments may have been, she wasn't thinking that it would bring back traumatic memory, we have to help her understand, because he's dangerous at home. She's worried about her 5-year-old daughter and herself. And this is something we need, and we have tools to work with families to help them understand this. What about the school? Everything needs to go here. What does it mean? How do they communicate with Shane in a way that leads to him getting dysregulated in this way? Also, within the bounds of reality, of course, a kid is going to hear comments that feel demeaning, make him feel weak. That's just reality. So we need to help him build emotional regulation skills in order to what's he going to do when someone says something, that he choked in a basketball practice or whatever. How can he hang on to his feelings and understand? There's lots of tried and true emotional regulation, skill building exercise that we bring in here. And then we also occasionally integrate pharmacology. We really try and minimize it, but it may be that he's not able to make use of treatment if he's so dysregulated. Maybe, maybe not. We have a very specific focus of pharmacology. So TST has several components. We call it the workflow. First, assessment. Gathering information you need to consider what to do. You have to assess Shane, his mother, his family, his school, to know what to do. And within that, treatment planning is taking the information to making decisions, and we have a very specific way of doing this. So let's say you have ideas about what will help. Well, where is the family? Engagement is important. We have to know what's most important to the family, what might be valuable. So for Shane's mother, for example, we would assess what's most important to her. It may be she's worried about losing her job because she keeps being called to the school because Shane is aggressive. Or it may be she wants a partner and Shane's too aggressive, people are staying away. Whatever is her most important thing, we want to provide value through that understanding. And it may be that because she unknowingly is doing things that lead to Shane getting aggressive and then her not getting what she needs. That's the point of engagement. There's a lot to engagement, of course. It's critically important. And I'm going very fast, I know, within the time, but nothing is going to work, we know, unless we build engagement to add value based on not our perspective, but the people we work with's perspective. And then finally doing it. Okay, it's all lined up. Doing it within a team, and the team has different representation on the team. And then we have 3 phases. Safety-focused treatment, regulation-focused treatment, and beyond trauma treatment. In essence, safety-focused treatment means bad things can happen. Like Shane, he could really harm someone. Bad things can happen. We have a focus there to create stability and safety in the environment. Regulation focus, once people graduate from safety focused, or they may start in regulation focus, but most of the kids and families for you will be starting in safety focused. Once stability happens, regulation focused, and then beyond trauma is helping a child and family live their life without people like us. Adam, why don't you?
Sure. Thanks, Glenn. Okay, so who is trauma systems therapy for? We developed it for a wide variety of children who meet these criteria. A plausible trauma history, that means we may or may not have the details of it, but there's enough reason on the team to suspect that a child has experienced traumatic events, and that child has difficulty regulating their emotions and behaviors in a way that's likely related to those traumatic events. TST is for children 4 and above, up to young adults. It will work with transition age youth up to 21. And we work with children in many different settings with many different presentations. There are no explicit exclusion criteria as long as we're able to work with and engage children and families. There are certainly a number of studies on TST. I'm just going to briefly mention 2 of them. The first one, because it is the most recent, the Bridging the Way Home study was a study of 1,500 youth in foster care in the state of Kansas who received trauma systems therapy over a multi-year period. The study looked at not only the implementation of TST, but also the adherence to fidelity. What we found was significant improvements in emotional regulation, behavioral regulation related to higher levels of TST fidelity. We also found greater placement stability, meaning fewer negative placement moves after TST was implemented in foster care. There were non-significant improvements in permanency, likely because, the study didn't follow kids, throughout their time in care. But the fact that there were fewer placement moves was a very important finding. Outcomes were greatest the more providers around the child delivered care with fidelity. And again, because TST is a multidisciplinary team, we looked at the level to the degree to which the multiple providers were adhering to fidelity. And so we refer to this as concerted care. This study was actually published as 2 twin papers, one on the outcomes that I just mentioned and another on the implementation, because we put a lot of emphasis on how we implement TST, and that's another paper to look at as well. The other study I wanted to focus on is relevant because it looked at children in a prevention setting in upstate New York. And we found these were pairs of child welfare prevention workers and mental health therapists who went into the home and community to work together. We found significant improvements in emotion regulation, behavioral regulation, and the increased stability of the child's environment. Post-implementation hospitalization days increased by 36%, and post-implementation days in care decreased by 23%, and significant estimated cost savings was noted as well. We are implementing trauma systems therapy in multiple states throughout the U.S. We're in over 16 states and the District of Columbia. We're also implementing in child welfare settings in Singapore. There is expectation of fidelity to the model, but we also recognize that there need to be adaptations for different populations at different service settings, and we refer to the folks who are implementing TST as part of our innovation community. We encourage folks with us to develop the adaptations we call innovations to make it successful in their setting. We have a monthly meeting of the TST innovation community. And through those partnerships, we have developed adaptations of TST for multiple populations and service settings, including outpatient therapy, residential programs, foster care, prevention. We're doing prevention work all over the country, including New York City. We have adaptations of TST for refugee populations, juvenile justice settings, substance abuse, mental health programs, community-based prevention, and school-based mental health. The way it typically works is, as Glenn mentioned, TST is delivered through a multidisciplinary team. One of our main concepts is no one should ever have to worry alone. And because we know how complex these children and families are, there is a lot of worrying to be done, and we do it in a multidisciplinary team. Because, as Glenn mentioned, we are a phase-based model, the safety-focused phase is largely about home and community-based stabilization, but the regulation and beyond trauma phases include mental health therapy. So we do need to have master's level clinical folks as well as case managers. In some prevention settings, that is done as a dyad. In others, it is one person providing both of those functions. And as Glenn mentioned, there is an organizational planning process. And when we work with an organization, the first couple of months are figuring out what it's going to look like and what is going to work best in your setting. We look to integrate the psychopharmacologist as part of the multidisciplinary team. The team meets weekly to discuss cases and to support the team in learning the model and in supporting each other through this difficult work. TST works within existing caseload expectations. It is not meant to change caseloads. It's meant to help you work more efficiently and more effectively within the mandates that you have to work with. In New York City, it will likely be caseloads of 8 families. And supervisors are trained along with direct care providers so that supervision can include support of providers and provide adherence to fidelity. The length of service can vary. Most youth in a preventive setting are likely going to be starting in the safety-focused phase, in which case the length of treatment will be somewhere between 4 to 12 months. If a child starts in regulation-focused, it's more like 2 to 6 months. We have an extensive and detailed process of assessment, treatment planning, treatment intervention, engagement, and fidelity monitoring. There are very specific tools to help with all of those things, which are gone into in great detail in the training. The point of training is to get organizations to be able to be sustainable without requiring the ongoing consultation from us. It begins with organizational planning, as Glenn mentioned, to really understand the working of the agency and how TST can help to achieve the most important goals of the organization. We come on site and do a 3-day training. Everyone who's going to be on the actual teams participates in the 3-day training, but we often invite other people in the organization and significant community partners to come to at least the first half of day 1. Following the training, the multidisciplinary team meets weekly with a TST consultant on the phone, helping the team as they work through cases in the model. We also develop internal expertise. We call these folks TST experts, and we're also having a weekly consult with the TST experts to help them develop the expertise to monitor fidelity, to be able to train internally, and to supervise and lead the team meetings. At the 10-month period, we reevaluate with the leadership team to see how things are going and determine readiness for sustainability or whether additional support from our team would be necessary. So we develop TST experts who are going to be able to sustain this over time. The team always has access to the innovation community. They're invited to be part of the monthly calls, and they have access to us as well. The TST Training Institute is available for expert support, for program evaluation consultation, and any other training needs that may be there. Glenn and I are certainly happy to consult with anyone who has questions for us outside of this building, and hope to meet some of you soon.
Okay, great.
Okay, just a few announcements before we wrap up here. As I mentioned ahead of the presentations, we have posted all of the materials online at this web link, so please make note of this link. The PowerPoint presentations are available there for these sessions, as well as the family support session last week, and all the handouts. And then after the session, we'll be posting videos. This is a public link on the ACS website, so you can forward this along to anybody on your team who is not able to be here today. If you want to revisit some of what was said, you're welcome to go back and watch it as many times as you like. It's available there for you. All right. And then questions. If you have questions today about the models, about the RFP, this is the email address to send those to. Please note, no ACS staff can answer your questions. All the questions about the RFP have to go to this inbox per procurement rules. So if you have any questions, write it up, send it here. We're getting back to folks within a couple of days typically. So when you send an email to this box, you will get a personal response to your question within a few days. And then all of these questions will be posted as an addendum to the RFP after the pre-proposal conferences. So everyone will have access to the bank of all the questions and answers. Just note, your questions will be made public, but your identity will not be associated with the questions. That'll be anonymous, but your question will go out as part of an RFP addendum, and that'll be sent to all the email boxes. Pre-proposal conferences, these are your opportunities to ask questions in person. We're hosting 2 of these. The first is on Monday, July 8th. It'll be here. Just note, we're limiting it to 2 representatives per agency, just like this event, and you'll RSVP online, just like you did today, in the link that's in the actual RFP. The second event will be Wednesday, July 17th, also here, same deal, 2 representatives, and RSVP via the link in the RFP. Just to note, these are 2 interchangeable events. You don't need to attend both. Just choose the one that's most convenient for you, and please join us if you like. It's optional, but recommended. With that, I think we are finished with this session for today. We're going to go out for lunch. If you're registered for Block C, please be back here in your seats by 1:55 ideally, and we'll see you then. Thank you.